Okay, it's 6:01, and if it's all right with everybody, we'll start up. And probably, if it works for you, and I guess I need help, probably do a 10-minute bathroom break every hour. But again, whatever you think, whatever's been done, you're going to have to kind of guide me, as I haven't been in on many of these sessions. Anyway, tonight's subject is the plant and animal emergencies. And of course, you saw the blurb at the beginning, meets the chapter objectives and so on. The with the cross with a dot meets the chapter objective. The key term identifies a key term. The key term will be underlined for easy identification. And what we want to do is describe how plants and fungi can be harmful to humans, describe how mushrooms can be harmful to humans, describe and demonstrate how to assess a patient who's been injured following an encounter with a toxic plant, animal, or marine life, and describe and demonstrate how to manage an exposure to topical on-skin toxins. And we want to describe how to manage somebody who's been bitten by a poisonous snake, and describe the proper management of wounds caused by animals, including reptiles, insects, and spiders. Some of the key terms we're talking about is anti-venom. That's a anti-venom, venom. Woo. Did I fumble on that one? Envenomation, necrosis, poison, toxin, and a venom. The chapter overview, they talk about anybody who spent time in the outdoors should be aware of the risk posed by avalanches, lightning, or flash flooding. But more common are the injuries resulting from exposure to plants and animals. More ski reports such as ours getting involved in summertime activities like biking. Basic knowledge of these emergent medical problems is important. Even though most encounters with plants and animals are benign, certain plants are highly toxic, and most animal sightings are enjoyable events. However, big and small animals can inflict great injury. Talk about poison, toxins, and venom. A poison is any substance that can cause severe organ damage or death if ingested, inhaled, or injected into the body or absorbed through the skin. It can come from a living creature or from chemicals or substances that don't come from living creatures. A toxin, on the other hand, is a poison made by a living creature, whether it be a plant or an animal. And a venom is a specific toxin or poisonous secretion of an animal, most commonly from a snake, spider, or scorpion, and it's usually transmitted by a sting. Well, can you guys hear me okay? Any issues, or is this working okay?
Oh, it's working okay.
Good.
Okay. I'm hoping that you've gone through the book and this is just a fast review. And if so, if there are questions, interrupt me, just speak up. There's all these nice gadgets where you raise your hand, but just hit your mic and speak up. Those of you who are on mute, if you hold the space bar down, your mute symbol will disappear and your mic will be live. It's like a push to talk on the radio. Anyway, we talk about most toxic encounters from plants and animals. Plants and fungi are topical in nature. Outdoor enthusiasts sometimes ingest vegetables or fruit that is harmful. When eaten, some of the plants can cause life-threatening systemic reactions. The most common presentations of ingestion include nausea, vomiting. Body seems to know. Okay, let them come in here. John Chow is joining us. You know what happened? You click back and forth, you go in different places. All sorts of prizes. Okay, well, most toxic encounters from plants and fungi are topical. That means they're on the skin. Some, when you eat them, they cause some bad problems. Typical presentations are nausea, vomiting. They say the body seems to know the substance was eaten is toxic, so it tries to expel it. And it may produce cardiac effects, resulting in rhythm disturbances, neurologic effects, producing hallucinations, confusion, or seizures. The onset of the effects may occur within 15, 30 minutes or over several hours. Some plants have toxins with medicinal purposes when administered in small doses. An example, foxglove gives us digitalis. And they gotta let somebody else in. And when I did that, it popped back and forth. Foxglove gives us digitalis for the heart. Castor oil gives us castor oil as a laxative, and belladonna, which is used to treat diarrhea. When too much of the toxin in these plants is consumed, severe illness or death can occur. When plant toxins touch the skin, that's what they call a topical exposure. Localized skin reaction due to contact with plant material is common. Reactions are typically localized. You see the picture here. May cause itching or blisters and pain, and they can be severe enough to require evaluation by a doctor and treatment with medications. In severe cases, systemic effects may result in cardiovascular collapse or shock. There are three main types of mushrooms that are dangerous to humans. And I'm going to probably louse up the pronunciation, but there's the Amanita genus, false morels, and little brown mushrooms, which is a catch-all category. Mushrooms in these groups are responsible for the fatal mushroom poisoning in the United States. Amanita mushrooms alone count for about 90%. Most of the people are exposed by personal gathering and ingestion. And I think the comment on mushrooms is, unless you really know what you're doing, best spot to find mushrooms is in the supermarket. There are hundreds of other mushrooms that can also cause problems. Bottom line, they cause mild stomach ache, severe physical stress, including vomiting, diarrhea, cramps, and loss of coordination. Two common poisonous mushrooms of this type are the jack-o'-lantern and green spored lepiota. Effects usually pass in 24 hours or less with no lasting effects. But the onset of symptoms provides a general guide to the lethality, I should say, of the mushroom. The more benign species can cause gastrointestinal upset within the first 2 to 3 hours. More dangerous types have delayed symptoms up to 8 hours after ingestion. In addition, some mushrooms known as psilocybin contain chemicals that can cause hallucinogenic effects in humans and animals. Now, we talk about spiders. Localized necrosis, that's the deadening of the skin, infection at the bite site. In some cases, serious systemic illness can occur. The most harmful spiders in North America that bite are the black widow, brown recluse, hobo, wolf, and spider. And they show you pictures of them. I'm not sure the pictures here, but I don't really want to play with spiders. Any comments from anybody? Kimber, welcome. How are you doing today? Hold the space bar.
Good, thank you. How are you, Bob?
I'm doing well. If you hold the space bar down, it acts like a push to talk on a two-way radio. You just gotta hold it down. I leave mine on mute when I'm on a call, so you don't hear my wife yelling at me or the dogs barking.
Okay.
Hold the space bar down. It seems to work
Thank
pretty well. Yeah, we're all learning. I got to tell you, I'd sure rather be out on the hill than hiding like we are. We also talk about bees and wasps and hornets and yellow jackets, and they cause the most instances of venomation. Wow, that's quite a word. I think it just means getting stung. Most stings cause pain and swelling, the localized area in a nearby joint. We talk about patient assessment. In any harmful exposure to a plant or animal, OEC technicians must certainly determine whether the scene is safe. We hear over and over, scene safety, and scene safety. I can tell you that I've been working on some accidents below jumps, and even though we closed them off, we had people at one time jump over us. But anyway, we look at a plant or animal situation here, poison oak, poison ivy. It can harm the rescuer, creating a second patient. So we talk about scene safety, very important. Gloves, make sure you're not right in the patch of poison oak. I don't know if we've got poison oak in the ski area or not. I was raised in the Northwest, and we did see a lot of poison oak up there. Typically what they say on this is the patient is not responsive, open the airway, no pulse, immediately initiate CPR. This is the kind of thing that we've, everything we do is pretty much the same. check for breathing. If not, CPR, do the ABCDs, airway, breathing, circulation, disability. And during your initial assessment, look for neurological impairment, life-threatening external hemorrhage, signs of shock, or other serious trauma. Afterwards, we do a secondary assessment with sample and decap BTLS. We want to begin by determining if the problem was a bite or sting or exposure to a plant. We want to try to identify the source of a plant or animal-related problem, and trying to identify the source can be a challenging situation. I think one of the things we need to look at is if somebody has a reaction, find out if they've got an EpiPen. If they do, help them to inject it. I think that's probably a key takeaway. Martha, what would you say about that?
Definitely a key takeaway. If they're having an allergic reaction, check if they have an EpiPen.
Okay, if they don't have an EpiPen, what do you do? Martha, if they don't have an EpiPen,
Oh, you're asking me?
yeah,
Well, you've got a position. Use positioning to open the airway. Monitor the effects of possible swelling of the upper airway, tongue swelling, eye swelling. All those things are going to give you a high index of suspicion that you're going to have compromise imminently.
great. So no EpiPen, somebody's got the situation like that. What can we do? Martha?
No EpiPen, radio for help. And if you're having a patient with any kind of allergic reaction, you're going to want to have ALS on the way or ground transport on the way, because you're also going to want to possibly treat this person with Benadryl. But that's outside of the OEC scope.
Right.
I think a lot of things you're going to find is that you're going to need to assess and notice and then pass that information on.
Okay. One thing I guess we can do in that situation may help is oxygen. Okay, we look at the patient inspection assessment. We look at inspection. For an animal or insect injuries, we expose and assess the affected area. We're looking for things such as a rash, pale or discolored skin, and general swelling. And we want to closely examine the mouth and nose for evidence of swelling. Look for bite or fang marks. Assess the patient for nausea and vomiting. Carefully assess the cardiovascular, respiratory, and neurologic status. We want to reevaluate the patient frequently because vital signs may deteriorate quickly. Again, this may seem, gee, are we the ski patrol or what is this? But as you know, the area is opening up bike paths. So the area is going to become a winter and summer resort as this COVID subsides. Skin contact with certain toxic plant can cause serious skin-related problems, allergic reactions, localized inflammation, or trauma from spines and needles. We want to evaluate the skin for signs of rash or trauma. We want to look for gastrointestinal upset, abdominal pain, sometimes severe muscle aches, generalized weakness, and they're pretty common in the ingestion of toxic plants and mushrooms. Again, monitor the patient's vital signs frequently and evaluate for shock. Len, have you got any comments? Len Novak, you got any comments?
No, not right now.
Okay. All right, we're looking at insect bites, and you're seeing spider bites, scorpion stings. One thing with the spider bite, take a look at the lower picture here on my screen. Severe localized soft tissue injury and later tissue necrosis occurs. Pretty bad. Tick bites take a few days to a few weeks for systemic illness to result from a tick bite, although localized infection at the site may occur sooner. Here, take a look at you're seeing a picture of a tick. You're also seeing a irritation after the tick bite. They say ticks usually remain on the host body for an hour or two before attaching, so it's important to look for them and remove them as soon as they're discovered. Have the patient monitor the attachment site for developing rash. Now we're looking at stings from bees, wasps, hornets. What we've got here is somebody stepped on an ant's nest. The ants swarmed, came and bit the heck out of them. One comment about a bee sting: even if a person says they're not allergic to a bee sting, there's always a first time. Now we talk about injuries caused by mosquitoes, biting flies. We want to assess the affected area for localized inflammation, which in most cases should be minor. Insect-transmitted disease typically take several days to weeks to manifest, and given that mosquitoes can transmit serious diseases, we want to advise the patient to watch for signs of fever and systemic disease. Snake bites. I got to tell you, even a garter snake scares the daylights out of me. But again, what we want to do is assess the ABCDs. They talk about snake venom can cause severe systemic bleeding, neurologic paralysis, hypotension, delayed necrosis at the bite site. And again, it's monitor the vital signs. As we go on, one of the things we're going to talk about, I think we've all seen the movie where somebody gets bitten by a rattlesnake and the hero jumps in, cuts the area around it, sucks the venom out and spits it out. We read the book and say, no, that's not, first of all, it doesn't work. It just not, and spread the venom. They take, don't do it. We talk about most injuries, marine animals, local soft tissue damage, but some injuries can cause cardiovascular or neurologic instability. We want to evaluate the severity of any soft tissue injuries and monitor the vital signs. There's a stingray sitting there on the bottom. Unless they're scared, they're really sweet animals. I was in a place called Stingray City down by the Caymans. It was about 10, 12 feet of water. And the stingrays just kind of swam across us, and they love bald heads. We talk about large animal injuries, and we talk about paying close attention to excessive bleeding in the ABCDs. We perform a secondary patient assessment. This is just simple, trauma injury and normal procedure as you've been doing through the past 20 chapters, nothing really new here. Talk about management. As for any incident, you want to be sure the scene is safe. You want to observe the standard precautions to prevent contact with the plant toxins or animal transmitted diseases. We want to control excessive bleeding. We want to manage the ABC related problems. Again, if the patient's unresponsive, immediately open the airway, simultaneously check for breathing and carotid pulse. And if there's no pulse, begin CPR using the latest guidelines and request EMS. Patient position: in absence of significant trauma, place the patient in a position of comfort. And patients who are in shock, they want to be in a supine position and keep them warm. For breathing difficulties, high flow oxygen by non-rebreather mask. Want to titrate the oxygen level, the pulse oximeter, so we get between 94 and 99%. Any questions? Okay, further management of almost any serious animal-related injury or an envenomation or toxic ingestion should include urgent evacuation, transport to a definitive care facility. All right, based upon your choice of transport by ground or air, length of transport, severity, local protocols. And I don't know if this has been discussed already, but typically, unless somebody is in immediate severe distress, it's ground ambulance. but if there's something that's more urgent, then we request air. If somebody has been stung, they talk about scraping the skin, pardon me, let me just take a little sip of iced tea here. They say you're not supposed to eat on a Zoom call. I hope drinking iced tea is okay. If a stinger is present, they want to scrape the stinger off the skin using the edge of a flat object such as a credit card. Clean the bite area using soap and water. That's for bee stings, something like that. For spider bites, that's rather interesting. They want you to immobilize the area and to slow the spread of the venom. They also want to have you keep the infected area below the heart so that it doesn't pump through the body quite as quickly. And again, don't use a tourniquet unless there's severe bleeding. Again, we're referring to the auto-injector, the EpiPen. And I think one of the keys is use the patient's own medication only. Now, again, that's not what we see in the EMS services, but this is what we do as OEC technicians. Here's an interesting one, tick bites. If you find a tick on the person, I used to hear, well, you applied a hot match or fingernail polish, alcohol. Say, don't do it. You want to have a thin set of tweezers. You want to grab as close to the patient's surface of the skin as possible and gently pull the tick out. You don't want to crush the tick. You don't want to do any of these things because if you do, it's more apt to release its toxins into the body. And after the tick is removed, you can disinfect the skin with isopropyl alcohol or another disinfectant. Non-poisonous snake bites initially need only local care. Follow-up medical evaluation is advised because delayed infection or skin necrosis can occur. And make sure the snake wasn't a poisonous type. For all poisonous or non-identified snakes, make the safe scene by removing the person beyond the striking distance of the snake. Call for immediate transport to ALS. Have the patient lie down, have them calm. Place the limb below the level of the heart to slow the spread of the venom, just like we did with spiders. Anybody want to make a comment? Why are we going to remove jewelry from the area that was bitten?
For swelling.
For what?
For swelling reasons.
Right, for swelling, exactly. Same thing for the shoes. If you've got bleeding, if the wound is oozing, it's not arterial, let the bleeding continue. Cover the wound with a loose sterile bandage and apply a splint to avoid motion of an extremity. Because physical exertion should be avoided, don't allow the patient to hike out over a great distance because it's going to enhance the spread of the poison. I could make some comments, what we do is leave them there, but indicated, but it should only be administered by a physician or qualified person only. Martha, do they carry anti-venom on the rescue out of Kyle?
Negative. And I don't know what hospital carries what types of antivenom.
So Bob, I can jump in on that one. So antivenom goes by the name Crofab. Crofab is, last I heard, about $10,000 a vial. So it will never be found on an ambulance. And it has to be refrigerated. The shelf life is very short. And so only a handful of hospitals carry Crofab. I think Sunrise and UMC are the only two in town. I don't know if any other ERs do. However, a little tip about antivenom, the local poison control centers are responsible for coordination of antivenom in the area. So if you call your local poison control center, they can tell you what hospital to go to, or they can coordinate getting the antivenom to your location.
Sam, how would we call the poison center? Would we memorize their number or just dial 911 and ask to be connected to the poison center?
1-800-222-1222. I've got that memorized.
800.
222-1222.
1222. Okay, That's the Poison Control Center. Okay. Do you see a lot of it in Vegas, Sam?
No, we don't. However, as you get into the rural areas, but yeah, inside Vegas, really not that big of a thing.
I didn't know if you covered the kind of the outer areas, the hills and mountains and stuff. Well, let's flip on to the next slide here and see what we got here. All right, as I mentioned earlier, the outdated recommendations to suck the poison out, cut the wound to make it bleed. These methods don't work. They can worsen the envenomation. Don't apply a tourniquet, ice, or water to a snake bite. Don't give a patient alcohol, caffeinated beverages, or other medications. Antivenom may be indicated, but it should be administered by a physician or qualified person only. Well, I guess this OEC applies to all over the place, but if any of you see an alligator or crocodile, and you see somebody that's been bitten by an alligator or crocodile, treat for excessive bleeding, ABC problems immediately. Large reptiles such as alligators, crocodiles, generally cause crush injuries. I guess we do have some in our zoos here, but other than that, I don't see a lot of them. And again, just like anything else, massive bleeding, compressive dressings, tourniquets, again, as you would with any trauma situation. Marine bites and marine animal bites control bleeding, transport the patient, irrigate all wounds with fresh water, and apply appropriate dressing. If a life-threatening hemorrhage is present, a tourniquet or hemostatic dressing is recommended. I guess we're talking about shark. If present, remove the spines and decontaminate the affected area. X-ray imaging is usually done to look for retained foreign bodies. Biotics are routinely administered at the hospital. We're talking about, in this case, since this is outdoor emergency care, we're talking about scuba and snorkeling issues. The spines we're typically talking about are from a spiny sea urchin or something like that. As we get on, they're going to talk about what to do with stingrays and so on. If we encounter, and believe me, I've encountered a stingray. It's not nice. You want to prevent further discharge of the nematocysts. Wow, these breath. Let's just say the venom that stings. Pain relief. To inactivate the venom, you want to wash it off and you use vinegar for at least 30 seconds. Check with local authorities. It's been shown to work only for certain types of jellyfish. After the nematocysts are removed or inactivated with vinegar, the pain is treated by immersing the affected part in hot water for at least 20 minutes or longer. Patients with more systemic reaction should be urgently transported to a hospital. Again, something I've been involved with. Sea urchin spines. First immerse the affected area for 30 to 90 minutes in hot water or vinegar. Help soften or dissolve the spines. Use a tweezer to remove all the spines that are stuck. Apply shaving cream to the injured area and remove the movable stalk structures by scraping with a razor. Scrub the wound with soap and water and rinse the injury with fresh water. Again, some of these we sit here skip totally. Why? But most of us will have some other experiences, and we may well be in an area doing scuba diving and so on.
Just curious, Bob, why shaving cream?
Why shaving cream? Well, you're trying to run the razor across the spines, and you want to lubricate the skin. You don't cut.
Sorry, I missed the razor part. Never mind. I thought it was for non-shaving purpose.
No, I'll go back here. What you want to do is use the shaving cream and then scrape with a razor.
And it hooks to the spines then and pulls them out, or it just?
Good question. I don't know. Anybody make any? I think. I mean, when you read what the book says, it says movable stalked structures. So it sounds like your razor is catching on and pulling these stingers out. I hope it's not just cutting them off and leaving them in the skin. I don't know. This is a new one to me. I knew about the credit card. I knew about the vinegar. We had some people say, well, vinegar wasn't around, just pee on it. I've seen that done. And all I can really say.
So the principle of shaving cream is to lubricate the skin so the razor catches catches the hair and gets more of the hair out instead of dragging your skin along with the hair. So I think what they're trying to point out is if you're gonna try to shave off these whatever the injectable little needles, whatever they are, that it can be done easier and more effectively with shaving cream.
Thanks, Martha. That's you. Good comment. Thank you.
There's a lot of ski patrollers around the nation that are also scuba divers.
Well, I haven't been under several years, but yes, I have been underwater. As I mentioned, I've seen the stingrays and had them pat their bellies and so on. Okay, we talk about animal bites. We're looking at bleeding control, wound care, shock management. All animals, bites of all animals can contain multiple types of bacteria that can enter a victim's tissues through a bite. You want to wash the bite with sterile or clean water or saline solution, apply a sterile dressing, immobilize suspected fractures in the usual manner, recommend further medical care. Now, larger wounds often require thorough cleaning and closure with sutures by a physician. Smaller wounds, less than about 2 centimeters, and punctures are typically left open without drainage. Any wound debridement and repair, which is extensive, should be performed by a physician. Comment here, because many rodents carry infectious diseases, a patient with a bite from these animals should be promptly transported to a hospital for treatment. Dog and cat bites pose a high risk of infection, and prophylactic antibiotics are sometimes recommended. Now, we've got injuries caused by large animals. They're typically treated, just again, according to the signs and symptoms present. A large bite or kick requires the same type of care as indicated by a similar trauma caused by any other mechanism. You want to control external bleeding, splint, and provide spinal motion restriction if indicated. Again, this is just the same thing you would do with any other type of an injury. Because an attack from these animals can result in massive injuries, monitor vital signs carefully for signs of shock. Treat massive bleeding with compressive dressings, tourniquets, or hemostatic dressings using standard precautions. All right, now it gets to be more fun. Case study. You are at the mid-station of an off-road bicycle competition at a national park. A cyclist comes into the station, says somebody was attacked by a bear about a quarter mile back. You and another patroller grab your packs, get on an all-terrain vehicle with oxygen, medical equipment, and a stretcher, and head up the trail. A ranger with a rifle accompanies you on another ATV. A small crowd is gathered near the trail. You find a middle-aged man lying alongside the road, bleeding and confused. You scan your surroundings for wild animals and ask others if there are any near. None can be found. The ranger stands guard and keeps the crowd away from you, but stays close in case the bear returns. The race is stopped further up the trail. You ask the injured man his name. He replies, Mike. You tell him you're here to help him. His right arm has a large gash that is spurting bright red blood from severely damaged tissue. You control the bleeding with a pressure dressing. You notice he has a belt placed snugly around his upper right thigh with a large amount of tissue missing from his lower right. You immediately radio for help and EMS with air transport. What should you do now? Len, any comment?
Still reading here. Still thinking.
Bragg, any comment from you? Bragg, did I catch you?
Yeah, I'm here. I mean, you're already attempting to slow or stop the bleeding as much as possible. Called for transport. I guess maybe oxygen would be a okay answer. And you just kind of got to secure the scene and wait for the transport to get there at that point, I think.
Well, we talked about controlling the bleeding in the arm with a pressure dressing, but you notice he's got a belt placed snugly around his upper right thigh. There's
Real tourniquet.
a large amount of tissue missing from the lower right calf. So you radio for transport. What else do you think we ought to do?
A real tourniquet.
Okay. Abigail, you got any thoughts?
If a belt would be a sufficient tourniquet, don't you think? I mean, taking it off and putting something else on would kind of be backtracking, I think.
Just add a real
Yeah, it'd
one.
be good to leave it there and ask him what time he placed it on.
Okay. So we're going to time the tourniquet.
You
Do
could
you
put
think
a
we ought to leave the belt as a tourniquet, or do you think maybe we ought to put a regular tourniquet on, one that we can control a little better than the belt?
Yeah, and put it closer to the injury so he doesn't have to like potentially lose his whole leg.
Okay.
What about controlling the bleed? I know that they wrapped the right forearm, but it says it's spurting. I would be concerned about making sure that that's not going to continue to spurt as well.
Okay. Other thoughts?
Once the tourniquet was placed, you can't you remove it.
Yeah, but if he's got the belt there, then we can use our tourniquet to help with the upper arm.
Yeah, couldn't you leave the belt on and then apply another tourniquet,
Yes,
either
you
proximal or distal to it, and then with that, take off the belt?
Then I would think they would build up pressure above the belt, and then releasing that pressure would have a flush that would possibly break past your second tourniquet.
So in the Stop the Bleed class I took, they did.
Sam, what do you think? You with us?
I'm sorry. I'm doing something else.
Sam, the question is, we've got a patient. And we've got a major chunk of his lower right calf missing. He has he's put a belt around his upper right thigh to control the bleeding. Obviously, we're going to put a pressure bandage over the right calf. Should we continue to use the belt, or should we put a tourniquet in place ourselves? Or what do you think we should
Oh, hell
do?
no. Don't leave that belt in place. So, common misconception, right? Belts are great tourniquets. False. Don't ever use a belt as a tourniquet. Belts make horrible tourniquets. Where tourniquets get their action from is the windlass, right? So, let me give you an example, right? So, right now, if you guys see my camera, I am, you see my midsection. I just took my belt off, right? Simply by placing a belt over a wound, right? What's this gonna do, right? Absolutely nothing. Where a tourniquet comes into play is by using something like either a pen or screwdriver to be able to turn and really crank that in. I'm taking that belt off as quickly as possible. I'm getting a tourniquet on as quickly as we can, and we're getting him out of there.
Thank you, Sam.
Good job.
As I get dressed back on camera.
If I had done that, my pants would probably fall down and be very embarrassing for everybody, but that was good. Sam, you did good. John, you got any comments?
I guess other than that, start treating for shock, so like power, position, oxygen, keep him warm, and get him out of there.
Sounds good to me. Anybody else have any thoughts? Okay, so what we did was we called for transport, air transport. We controlled the bleeding on the right forearm with a pressure bandage. We controlled it there. We removed the belt and we used a regular tourniquet, which we have the ability to control the bleeding. Now, obviously, if we are able to, with a pressure bandage, control the bleeding at the lower leg, we've got the tourniquet in place. It doesn't mean it has to be cranked down. In fact, if we can avoid it, if we can control the bleeding without it, so much the better, because we're going to reduce the possibility of injury of the leg. Anybody have any other thoughts there? Okay, here's what they did. The landing zone had been set up near the admin building. As you approach the landing zone, the helicopter is about to land. After landing, paramedic evaluates your patient, starts an IV line, provides medications, loads him into the helicopter. Later, you discover the patient spent several hours in surgery, having his wounds cleaned and repaired. He received a blood transfusion. Long road to recovery is needed, but his life was saved. The park ranger later finds a den 200 yards from the bicycle trail with 2 bear cubs. The female bear was just protecting her young. Okay, how about a break, about a 10-minute bio break? Would you guys like that? Okay, I've got quarter of. Let's try and come back at 5 of. That's okay? This is going to be a little more interesting chapter. It seems a little more germane. I went through all of these, just kind of looking at them. And I'm going to put some in my face here, so I know you're not supposed to eat on the screen, so I can either click it or just go like this. We're going to talk about altitude-related emergencies. And it's important because the ski area, bottom of the ski area is about 8,600 feet above sea level. The top of the area of the lift is about 9,400 feet. And we're going to talk a little about hypoxia and what happens at altitude. We're going to learn what the definition of altitude is, at just the distance above sea level. We're going to talk about what happens to the oxygen as the altitude increases. We're going to list factors for development of altitude sickness, altitude illness, and strategies to prevent illness. We're going to listen to the signs and symptoms of the following altitude acute sickness, which is AMS, high altitude pulmonary edema, which abbreviated HAPE, and high altitude cerebral edema, which is HACE. We're going to describe how to assess a patient with altitude illness, describe the treatment of a patient with altitude illness. They're going to talk about acclimatization. These are key terms. We're going to talk about illnesses, ataxia, a gamma bag, altitude cerebral edema, and pulmonary edema. Seems like it's repetitive. Gumbo cough and a sleeping altitude. Now, I used to live in Denver, and I ski patrolled at Loveland Basin, which is right on the Continental Divide, also A Basin. The top of A Basin is at about 14,000 feet. And we would sit there and patrol, and we'd go there, and every winter we'd have some Texans come up. And they drove all night from Texas, sea level. They'd imbibed quite a bit of alcohol, and they got to the ski area, and they would fall like flies. So we had a lot of experience with this altitude sickness issues. Unsuspecting or unprepared people can quickly experience a miserable or even life-threatening event that includes intensive headaches, breathing difficulty, coughing spells, pulmonary edema, coma-inducing brain swelling, or even death. Even hardy recreationalists are at risk. They say that about 30% of the visitors to the high altitude resorts of Colorado get it. About 50% of all the hikers in the Himalayas suffer from some sort of altitude illness. And OEC techs who work in the high altitude mountain resorts may encounter patients who are suffering from altitude related illness. You will get people at Lee Canyon who come in with a headache, the symptoms, they are getting it. The good thing is it's treatable and it isn't too bad to work with. The body's ability to preserve homeostasis includes the ability to adapt to changes in altitude. Altitude is the height or vertical elevation above sea level, which is 0 feet. Most altitude illness occurs at elevations higher than 8,000 feet above sea level, but can occur at altitudes as low as 6,500. I believe that this picture right here is the top of the tram at Snow. In fact, it is the top of the tram at Snowbird. I noticed the Snowbird logo. I used to live in Salt Lake as well, and this looked pretty familiar. Rate of ascent is real important in determining the probability of developing altitude sickness. Rapid ascent is more likely to cause problems than a slower ascent. Even though the deadliest forms of altitude sickness occur more frequently at extreme elevations, they can occur at intermediate altitudes as well. Scientific evidence suggests that the genetic makeup of some individuals helps them avoid altitude illness and acclimate to high altitudes more easily than other individuals. I'm in Summerlin. I'm at about 2,600 feet above sea level. Some of you may be a little lower than that. The floor of the valley is about 2,200 feet. Again, remember, the top of the lifts are 9,400 feet. You will have people who have some altitude issues. Okay, altitude dramatically affects the amount of oxygen available to the body cells. Low blood oxygen content is called hypoxemia. As altitude increases, the atmosphere contains less air. At high altitude, the oxygen concentration remains the same at about 21%, but the amount of oxygen contained in 1 cubic foot of air at high altitude is less than 1 foot at sea level. About 10,000 feet, the oxygen taken in with each breath is only about 69% of that taken in at sea level. Serious medical consequences of ascending to a high altitude can be prevented through acclimatization, which is the body's process of gradual adjustment to changes in altitude. Now, if we were in Colorado, I would say, look, come on in from Texas, spend a night or two in Denver, 5,000 feet before you come up to the ski area. Don't just go straight from Dallas to the airport to the ski area. You may have a problem. The ability to adapt has allowed humans to travel to and inhabit some of the most inhospitable places on Earth at high elevations. You know, with less oxygen, the body must adjust to improve the delivery of the oxygen to the tissues and cells. Here are some of the keys. When traveling to high altitude too rapidly, altitude illness may occur because the body may not adjust fast enough to keep up with the body's oxygen demand. Keys to preventing altitude sickness, illness are knowing when to expect it, how to avoid it, how to identify it, and what to do if the symptoms arise. During acclimatization, the body makes a series of physiological adjustments that increase the delivery of oxygen to the body's cell. Gradual adjustment to hypoxia allows a person to temporarily endure extreme altitudes. Physiological adaptations that help preserve homeostasis include the following: increased rate and depth of respiration, increased heart rate, increased red blood production, constriction of pulmonary blood vessels, and increased urine production. Again, some people can adapt quickly, whereas others develop varying degrees of altitude illness. The severity of the illness depends upon how fast you came up to the mountains, the ultimate elevation attained, and they talk about the sleeping altitude. Now again, this tends to be for the mountain climbers where they say climb up to your elevation, then drop back 500 feet when you sleep. I don't think it really applies here, but again, it would apply if you're going to Denver, if you're going to go skiing there. Sleep down in the valley before you go up to the mountains, if at all possible. We're going to talk about altitude-related problems. AMS, altitude mountain sickness, that's a mountain medical condition caused by exposure to high altitude. It usually occurs within several hours to a day after ascending to a higher altitude. It occurs when the rate of ascent outpaces the body's ability to adjust to the change in altitude. It rarely occurs at altitude below 6,500, more often greater than 8,000. Now again, this is kind of repetitious, but we're saying AMS affects about 25% of all visitors who sleep above 8,000 feet in Colorado. Typically, AMS is characterized by mild to moderate headache, accompanied by one or more of the following symptoms: dizziness, fatigue, dyspnea or exertion, I should say, loss of appetite, nausea, general just feeling yucky. Headache typically develops in 2 to 12 hours. Now we're going to talk, by the way, we're going to, as we go through these definitions, we're going to go further on. We'll talk about what you do, which is basically going to give them oxygen and get them down to a lower elevation. But we talk about high altitude pulmonary edema. That's HAPE. That's a condition in which fluid accumulates in the lungs. It's not due to a pre-existing cardiac disorder. The fluid builds up in the lungs because the heart is not pumping correctly. It's caused by excessive blood pressure in the pulmonary artery. When at high altitude, it is thought the body is stressed by cold, exertion, anoxia, causing HAPE. HAPE is the most common cause of altitude death and rarely occurs at elevation below 8,000 feet. Like AMS, HAPE develops as a result of several factors, including several individual susceptibility, ascent rate, altitude reached by physical exertion. Again, typically, first 2 to 4 days of ascent to altitudes above 8,200 feet, and is heralded by the onset of marked fatigue during exercise. Untreated, fatigue is soon accompanied by severe dyspnea upon exertion, such as walking uphill or stairs. Let me take a breather and just ask any questions about what we're talking about. Again, this should be just a review of the chapter that you've already read. Len, any comments?
Not right now.
Alex, any comment? Okay. Again, I feel like I'm kind of reading you the slides, but again, this is a kind of a quick review of what you read in the chapters. And I've got a phone call we're going to dump. Oh, no more robo grab that it just shows incoming call. I don't even we'll get rid of that puppy. I'm going to dump this call. Just a second. Okay, it was my daughter calling. She just moved into a new house. She's probably got all sorts of issues. Anyway, we talk about in HAPE, patients may complain about a persistent dry cough during the early stages, and their nail beds, their lips may become cyanotic. Typically worsens at night. Labored breathing at rest, audible chest congestion herald the development of a serious, potentially life-threatening condition. HAPE may strike abruptly. Pink, frothy sputum is a very late finding and is accompanied by profound hypoxia. Untreated, HAPE can be fatal within a few hours. Fortunately, it can be easily reversed if recognized early and treated properly. Now we're going to talk about HACE, which is the high altitude cerebral edema. Basically, it's a brain bleed, which the brain is swelling. Most severe form of altitude illness is typically encountered most commonly at elevations over 9,600 feet. Again, HAPE or HAPE may be preceded by AMS. About 3% of patients who develop AMS go on to develop HACE. HACE is a true medical emergency and can rapidly lead to death if not recognized and quickly treated. Again, HACE is characterized by a progression of symptoms that usually begins with a headache, nausea, progresses to ataxia, plus any of the following signs and symptoms: altered mental status, fatigue, drowsiness, difficulty speaking, paralysis, coma, and death. And hallucinations, psychotic behavior are also commonly observed. It's not common, but seizures can also occur. I don't think you're going to see this at Lee Canyon. But again, your OEC, when you take your OEC test and you're certified, it's very possible you may move to Colorado. You may be at a high altitude area. This is one, Kumbu cough. It's a new one to me, but it's also known as high altitude bronchitis. Dry, persistent cough that affects nearly all people who spend time at altitudes above 14,000 feet. The coughing can be so severe, it can break ribs. The condition is named after the Kumbu region of Nepal near Mount Everest, where it was first observed. Let's talk about prevention. First of all, I think the key things are exceptional health or physical fitness does not render one immune to altitude sickness. Prevention of altitude illness depends upon proper acclimatization. I think that's a key word that we see here. The prevention depends upon proper acclimatization. The best way to achieve the proper acclimatization is gradual descent. If you begin at sea level, continue to above 10,000 feet, incorporate a layer of 2 to 3 days in an intermediate altitude. That's between 8 and 10,000 feet. For individuals traveling from sea level, 1 day layover at 6,000 feet can dramatically decrease the risk of becoming ill. Any of you ever ski the Denver area? Nobody ski the Denver area?
It's on my list to do.
Well, Dean, one of the things you can do as we get back to some degree of normalcy, the area runs powder up at, I'm sorry, I'm just blanking. I'm blanking the name of the ski area. I've skied it up in Colorado. Is it a Copper Mountain? I'm sorry. And Copper at the top of the hill is about 14,000 feet. The bottom of the hill is probably about 10,000 feet. And again, as things get back to normal, you will be able to ski there. You'll be given passes. You'll be able to do that. So some of these things, even though you won't be patrolling, you'll want to, these things we're talking about do make some sense. Anyway, when you get there, you go to Colorado, don't go straight to the area. Spend a day or so in Denver, acclimate a little bit. And again, you can read this as well as I can.
Makes sense.
Yeah. Now that I'm living here in Vegas, when I go to Colorado the first few days, I feel like I'm hyper. I have difficulty sleeping the first night in Denver. Then I acclimate and everything is fine. Now, I lived in Denver, of course, I slept like a baby.
Is it true that drinking more amounts of water than normal helps with altitude sickness?
Absolutely, because not only altitude sickness, but because you're in the high dry area, you're going to expel a lot of moisture from your body. So you're going to be thirsty. Absolutely drink water. We also talked about earlier some of the effects of urinating more. So you want to replace the fluid in your body. I think this answers your question. Stay hydrated. Take it easy for the first 24 hours, 48 hours. Alcohol, not great. If you begin symptoms of altitude sickness, don't go higher till the symptoms resolved. Climb high, sleep low. My wife has just come in here, and she's gonna feed the white monster cookies. Okay, there are several prescription and over-the-counter medications that can reduce or even prevent altitude illness. OEC Tech should specifically ask high-altitude patients during the sample history whether they've taken one of these medications. Dimox is a prescription medication that's often taken prophylactically to prevent AMS. Effects may be delayed, so it's advisable to wait about 24 hours before you ascend. Martha, have you had any involvement with this Diamox?
Negative. I've never heard of it or asked anybody about it. Usually we see mild headaches and nausea, general fatigue. We really see a lot of AMS. I think really the point of some of this chapter is if it progresses into an altered mental status or a pulmonary problems.
And what do we do for when somebody comes to first aid room? I'm feeling nauseous. I got a headache. We put a pulse ox on them, and we see that their pulse are low. What do you typically read, see, and do, Mark?
Whatever your findings on the pulse ox. If you have a low finding on a pulse ox, then it's more than just AMS, acute mountain sickness. If you find a low finding on a pulse ox, I would think that you're getting into pulmonary edema. So you want to listen to your lung sounds and things like that. Usually if you have these vague symptoms with a patient that has really no trauma attributed to any of that, altitude, if you give them oxygen, they start to feel better. A lot of the history that I go with is, are you visiting Vegas? We do get people visiting from the California coast or Hawaii. So we actually have people coming from actual sea level. Vegas is 2,500 feet. And then, so I mean, that is still a very low altitude compared to now you have to climb 6,000 feet in about an hour and a half. So that's what we usually find is that people that are unaccustomed to coming up here, and it's a very rapid rise. Does that make sense, everyone?
Martha, what do we typically see as a pulse ox percentage up at the ski area of people?
I'm happy with 92 and above. So with no other symptoms, that kind of brings up to anytime you're taking even some of the, you're just splinting a wrist or something like that, go ahead and take all your vital signs, because the more normal signs you see, the easier it is to pick out the abnormal patterns. So I'm pretty happy when I see somebody with no breathing difficulties, no signs of hypoxia, confusion, with a 92 up at our altitude, that's fine. So that's good. It should be above, like 94 and above down in the valley.
Okay, great. I don't know if some of you know, but Martha, you've driven ambulances for how many years?
I don't remember.
Okay, my background was certainly not the EMS that Martha has and Sam has. That's why I lean on them for some questions. Here's some interesting things. Viagra and Cialis seem to prevent altitude illness because they dilate the pulmonary arteries. Adalat has been also used to prevent HAPE, I should say, in people susceptible to high altitude illness. So maybe the answer is take your Viagra before you leave Texas, right? Okay, the role of OEC technicians is not to diagnose the underlying cause of a problem, but instead recognize the patients of the signs and symptoms of an emergency condition and quickly initiate life-saving treatment if needed. As with any patient, the assessment process begins with a careful examination of the ABCDs. If a potentially emergent condition exists, initiate life-saving treatment instead of performing a complete physical exam, and refer the patient to a higher level of care. That's a lot of words there. I think the bottom line is if we have an issue with the mountains, put them on oxygen and get them down to a lower altitude. If anybody has any comment to contradict this, I'll certainly be willing to listen. Again, we should be looking at the medical history sample and the PQ, RST, mnemonic respectively. Whether patients might have an underlying cardiac or respiratory condition could be worsened by altitude. Individuals with sleep apnea, they say, may become severely hypoxic at high altitudes. Ask the patient about this condition during your evaluation. I'll make a comment. I have sleep apnea. I don't have the problem. So whatever. Patients who are experiencing shortness of breath, ask them if it's associated with any pain or persists during rest. Ask the patient if they've ever had problems like this on previous visits to high altitude. Also ask patients if they have any AMS-related symptoms, such as headache, difficulty sleeping, nausea, vomiting, or excessive fatigue. All right, you want to place the patient in a position of comfort, may well be in an upright position. See if they're short of breath at rest. You're looking at the lips, the gums, nail beds for discolorization or cyanosis. You're looking at the face, hands, ankles, feet for swelling, edema. Examine the inside of the mouth for any pink, blood-tinged saliva or sputum. That's what we're talking about with the HAPE. If a stethoscope is available and you are trained, listen to the lungs for abnormal sounds that could indicate the presence of pulmonary edema. And see if there are any visual problems, especially a decrease in acuity. You want to complete the physical exam by thoroughly palpating the body for areas of tenderness or swelling. You want to assess the distal skin temperature, circulation, movement, and sensation. For patients who are complaining of symptoms that suggest AMS or HACE, attempt to assess them for ataxia by asking them to walk a straight line, heel or toe. Who wants to give me the definition of ataxia? Come on, you guys read it?
Is it impaired? Like
It's a loss of the control of your body movements.
Okay, sounds good to me. Did read it, that's great. Alrighty. Again, performing is reassess, including vitals. And we do have vitals forms, and where you've got them timed. You're looking not only at the absolute number on the vitals, but you're looking at a change over time. We'll talk about management of the high altitude related emergencies. Typically, get them to a lower elevation and give them oxygen. The oxygen is not a cannula. Initially, you're going to use the high flow oxygen by a non-rebreather mask, keeping the oxygen saturation between 94 and 99%. What is the flow rate we typically use with a non-rebreather mask?
10 to 15.
10 to 15, right. And we keep them warm by using jackets, typically treat for shock. Okay, remember this, they may be, anticipate vomiting. Remember this, they may be nauseous. So be ready to remove the oxygen mask, turn the patient on their side. We've got the suctioners. I've never had it happen, but it can. Treatment of AMS centers on treating the symptoms, holding the ascent, waiting for the acclimatization. Again, this sounds kind of crazy here because we're a day area, but in Colorado where somebody comes up from Texas and ends up in Vail or Aspen, this very much applies. We talked about high flow oxygen. Headache, telltime tale of AMS. The patient may self-administer things such as acetaminophen or ibuprofen. Again, water is good. Water is good. Again, if oxygen is not available, and we do have oxygen, so that's not an issue for us, get them down to a lower elevation. We talk about transporting in a sitting position as rapidly as possible. And rescue groups should make delivery of oxygen to a patient a high priority. If unlimited oxygen is available, descent may be delayed. Again, what we're looking at here is mountain climbing. So if unlimited oxygen is available, descent may be delayed for rescue safety because oxygen immediately reduces the pulmonary arterial blood pressure. In severe cases, the use of generalized or specialized bags such as the Gamo bag can be life-saving. We don't have one at the area. Okay, somebody goes to a lower elevation, resume normal activities gradually, warn them, can take up to a couple of weeks to recover their strength completely. A lot of this is repetitive. We talk about high flow oxygen, decrease the elevation. We're talking about high altitude cerebral edema. Patients should be transported immediately to a hospital. I clicked the wrong button here and I got a screen change. How about that? Patients should be transported immediately to the hospital for definitive evaluation, which often includes administration of steroids to reduce cerebral swelling. We've got a case study right here, and you're working at first aid duty in the patrol room at a resort that's at 11,000 feet above sea level. 28-year-old woman slowly walks in complaining of shortness of breath, noting that she doesn't look well. She's slightly cyanotic around her lips. You help her to the nearest stretcher. She tells you she hasn't felt great since arriving after her flight, driving up from sea level yesterday. She denies any chest pain, says she's got a bad headache. She's tired, becomes short of breath, just walked to the bathroom, and she has a dry cough. She has no significant past medical history, has not suffered any recent trauma, and is not currently taking any prescribed medications. She appears very concerned, says, "I've never experienced anything like this in my life." What should you do? Anybody want to hazard? Fabio, I haven't heard of anything from you.
Yes.
What would you do?
Oxygen, as you said, oxygen, and get her to a lower altitude.
Okay. Kimber, great.
Take her vitals.
What did you say?
Take her vitals. Give her oxygen. Get her to a lower altitude.
Well, you're at the area. I mean, you're going to give her oxygen. You're going to take her vitals, and then you're going to suggest that she go to a lower area, lower elevation. Again, I think that some water would be a good idea.
Water.
Did you notice the comment here about coughing? Got a dry cough. What is that a symptom of?
High altitude.
High altitude pulmonary edema.
Okay, do you think she should do anything other than just go to a lower elevation? You've given her oxygen, you've given her water, and she's feeling better. You told her, look, you're going to have to. Your problem is the lack of oxygen up here. We need to get you down lower. Is there anything else that we should recommend?
Take her vitals and maybe call EMS if she's deteriorating.
Colin, what do you think? Is it Colin or Colin?
It's Colin. I would do the same thing.
Okay. Alexander, what do you think, Alex? Do you think because she's got the cough that you might want to suggest that she seek medical attention when she's down lower? No. Again, if you call EMS, call for an you've got her stabilized. She's breathing okay now. Do you think she needs to go out by ambulance or can she go out by private car?
If she's able to maintain her oxygen saturations, and the cough is not persistent at that point, then it would be probably okay to tell her she could go by car. But if she's continuing with that cough and there's potential that she has pulmonary edema, she probably should be taken down by ambulance just to make sure she is seen to.
Sam, have you got? Are you with us, Sam?
I am.
What would
I
you
like everyone's ideas.
What would you suggest?
Check your ABCs, do your primary assessment, get a full set of vital signs, send her down by ambulance.
You would send her down by ambulance, even though her ABCDs are she's stabilizing once you put her on oxygen?
Wouldn't you want to know what her vitals are? I mean, if they're deteriorating, you'd want to call EMS right away, right?
Absolutely. I mean, it doesn't hurt to get EMS coming, especially too. There's a whole host of other things that could be going on. I mean, obviously, altitude's the first thing that comes to mind, but we want to verify it's not something else. We don't have the ability to do EKGs and other things on patrol. So calling for EMS, you'll be able to get the other treatment plans like EKG, blood sugar, and try to figure out what could be the cause. But because we're at altitude and we're in the altitude chapter, absolutely, I mean, that's definitely what it is.
I'll pipe in here for a second. So I just read it, and other than, yeah, I like what everyone's saying. But so a 28-year-old woman may not have any other history, and she's saying, I have never experienced anything like this in my life. So sometimes with patients, if you're like, hey, is this a call for an ambulance or not? The patient really has the right to refuse it, but you want to jump in there and say, hey, let me start, get a higher level of care on the way for you. So it sounds like I've never experienced anything like this in my life. She might be asking, yeah, please, I want the highest care possible. She's coming to you for help. So just reading that, if you're having a question like, well, should I just send her POV or not? Get the ambulance on the way. And you can always continue to monitor her vital signs.
Martha, the trigger to me was the dry cough. If she just came into the first aid room, didn't feel real well, a little nauseous, I put her on oxygen, her vitals came up, everything was good, she felt good. I don't know that I would call for an ambulance. But with the dry cough, my concern would be the pulmonary edema. And that's why that was the trigger to me. Would you agree with that, or am I out of line?
Sure. And as you read these things, and for the class, these things are kind of funny sometimes because just going off of written words and not what the patient is presenting straight to you. So right now I'm reading slightly cyanotic. So you're getting skin signs too. So this person really doesn't look that well. So, no fault to being confused on if this is, getting a higher level care en route. But if you look at the small little hints there, slightly cyanotic, dry cough, the person stating that she's never felt like this. So we got it. We are definitely going to call for backup here.
Okay. It takes about, what, 20, 25 minutes to get somebody from Cow Canyon over?
Yeah, that sounds right.
And from in town, you're looking at 45 minutes to an hour for the ground ambulance, depending on where they're positioned. But again, they'll come over from Cow Canyon about 20 minutes, and the rescue's got various has things on their truck. Okay, let's move on a little bit. Here are some of the things that I'm going to throw you. Upon examination of the patient, you find that her breathing was labored, even at rest. She appears physically fit. She confirms by saying, I run more than 50 miles a week. Her heart rate was 116. What's a normal heart rate, everybody? Anybody want to come up with a guess? Remember that one?
Not
60.
116 unless you're in an activity.
What would a normal resting heart rate be, Len?
Resting heart rate for somebody who runs 50 miles a week, between 47 and 52.
Okay, but she's got some altitude. Okay, so she's got a pretty rapid heartbeat. Her blood pressure is a bit high. Respiration, she's sucking like mad. So again, pulse ox showed it was 84%. That would make somebody gasp. Trust me, I know it. Okay. So we talked about what was wrong with the patient, possible pulmonary edema. What should we do? Oxygen and call for transport, right? Okay, here's what we did. Here's what they say. We're concerned the patient had early signs of high altitude pulmonary embolism. We placed her on high flow oxygen, make her comfortable, mobilize the resource to transport her to a hospital. Her oxygen saturation remains at 98% by pulse ox. 2 days later, the patient's husband stops by, says, "Thanks for taking great care of my wife." He reports her symptoms completely resolved within a day after descent and administration of supplemental oxygen. He further states that the wife was advised to either avoid going to high altitude or ascend more slowly on her next trip to high elevation. She was encouraged to speak with her physician about using prophylactic medication that can help for future episodes of HAPE. I think we pretty well nailed this one as we talked about before I gave you the answers here. Okay, how about another 10-minute break and then we'll wrap this up. Would that be okay? It's 25 of 8. So at 7:45 we'll hit the final stretch. Is that all right with everybody?
Sounds good.
Okay, and I'm going to call my daughter, see what her issues are. Thank you. Sam, you with us?
I am here, Bob.
Okay, I have some questions. Are you doing the quizzes online now, or are we doing them somewhat verbally during the class, Sam?
Nope, all quizzes have moved online.
Okay, then I won't go through them. Okay. Alrighty. Well, let's start up again, everybody, with water-related emergencies, and we're going to be wrap this up pretty quickly. And you, so let me just get you going. We're looking at water-related emergencies, and we'll go right from here. We're going to learn how to define drowning, explain following water-related emergencies: arterial gas embolism, decompression sickness. We're going to talk about spinal injuries and what swimmer's ear is. We're going to how to assess a patient with one of the following water emergencies: drowning, descent emergencies, and ascent emergencies, and describe how to manage a patient who suffered one of the following water-related emergencies: drowning, descent, or ascent emergencies. And again, we'll talk about these as we go through them. Some of the key terms we're going to talk about is arterial gas embolism, AGE, barotrauma, decompression sickness, drowning, laryngospasm, mammalian diving reflex, and squeeze. Okay. Water-related injuries can occur at any time, at any place. When people think of a water emergency, the image they typically think about is somebody drowning in a recreational body of water, such as a swimming pool, a lake, or an ocean. Now, I hit too many buttons. All right, they say a drowning can occur in as little as 2 inches of water. You see the baby there. Okay, according to the Centers for Disease Control and Prevention, an average of 10 people die in the US from accidental drowning every day. About 500 drowning victims survive but are injured, and drowning ranks second only to driving as the cause of accidental death. It's a leading cause of death for infants and toddlers. Water temperature plays a significant role in the morbidity, and mortality of drowning victims. The survival rate is slightly higher for cold water immersions. When submerged in extremely cold water, the mammalian diving reflex helps to temporarily protect the heart and brain. Warm bloods gets shunt to the heart and brain. Body metabolic and heart rate slow significantly, reducing oxygen demand and conserving oxygen. That's the mammalian diving reflex. We're talking about prevention. Avoid alcohol, use proper safety equipment, fencing around the pools, and don't swim alone. We should monitor the activities of anyone who's near the water. Never enter swiftly moving water. Confirm the water depth before diving. Check the thickness of ice before traversing it. Scuba dive conservatively, ascend slowly while breathing normally. We'll talk about that. Watch for rip currents. Drowning typically progresses in the following sequence. Drowning is suffocation by submersion in water. Drowning typically progresses in the following sequence: panic, struggle with breath holding, submersion, gasp, swallowing of water with or without laryngospasm, hyperventilation, then hypoventilation, unresponsiveness, then apnea, relaxation of the laryngospasm, and finally cardiopulmonary arrest. Scuba dive injuries. Scuba. There are three phases of a dive: descent, bottom, and ascent. Now, they talk about barotrauma. When you go, some of you may have dove, may be divers, some may not. I'm a certified diver. When you go down, you're going to feel pressure in your ears. If you go down too quickly, you can rupture your ears. If you're plugged up, you've got a cold, you don't want to go down because you're not able to equalize. So we're talking about barotrauma, form of trauma that's caused by difference in pressure within the airfield structure of the body, that's the inner ear, and the pressure of the external environment. Such pressure differences result in the expansion or compression of the gas within the body structures. If the external pressure becomes too low, the unbalanced internal pressure within the structure can cause the structure to rupture. That would be coming up. That would be when you're coming up out of the depth. If the external pressure becomes too high, the internal pressure does not balance it and the organ is compressed. So in either way, you can blow out your eardrums. So if you are diving, watch yourself on pressure, listen to your body. There is a severe pain as the pressure inside the organ or body cavity can't adjust to the increased pressure when diving to depth. Resulting pressure is relieved by returning to the surface, thus equalizing the pressure. Similarly, how you pop your ears when you rise in an airplane. As you're going down, you go down slowly, you squeeze your nose, pop your ears, you go down slowly, everything will work out fine. Again, unless you're congested. Some people say take a Benadryl or an antihistamine before you dive. Not a great idea because you could have some other medical effects. Squeeze is a generic term applied to describe the effects of too much extreme pressure on the various parts of the body. I should say external, not extreme. I'm sorry. Okay, most commonly you're going to feel the pressure in your ears. Again, we talk about obstruction prevents the pressure of the middle ear from increasing to equalize the pressure outside. This is a more extreme version of the ear pain people experience during a descent in a plane. When you're scuba diving, driver breathes air, not oxygen. Faulty equipment can cause poor mixing of oxygen and carbon dioxide. Problems are rare but usually serious. Equipment failures during the deepest part of a dive can result in reduction or loss of air delivery to the diver. Descending on the depth, the diver may not have enough time to surface, even with rapid ascent before onset of an oxygen drowning. Wow, what is really saying is, if you don't have enough air and you're going down, you may run out of air. And even if you come up to the surface of the rapid going up rapidly, you can still have a problem, run out of air. As we go through some further slides, we'll talk about what you need to do if you're diving. If you are down at depth, you've got gas in your body and it's being pressed into you at a pressure that equals the outside pressure of the water. Now, if you hold your breath and go to the surface, the air is going to expand in your lungs. It will burst your lungs, very, very simply. So when you do come up to the surface from a dive, you're constantly blowing air out to equalize. One of the things they taught us when we first learned to dive was the dive master sat on the bottom of the ocean. We were only in about 20 or 30 feet of water. And he blew air into a balloon and he tied a knot in it. Then he brought the balloon up to the surface where there was less pressure and we saw the balloon expand. What he was trying to say is, this is what happens to your lungs if you hold your breath. So we talk about this. If this does happen, the gas in the lungs expands too much, the alveoli rupture, the air from the ruptured portion of the lung enters the bloodstream, resulting in air embolism. Air can get into the pleural space in the middle of the chest between the lungs, resulting in a pneumothorax or a pneumomedia. I'll work on that one. I thought I had it yesterday. At any rate, I'm not going to stumble on this longer. Let the air out gradually or it'll blow up your lungs. That's real simple. Decompression sickness. If you're down really deep and you're down for a period of time, the oxygen in your air, what you're getting into your mask is not pure oxygen. You're getting air, compressed air. The air is about, I think, 78% nitrogen. Nitrogen bubbles will develop in the blood vessels if you come up too rapidly because the nitrogen is dissolving in your blood. So you've got to come up very slowly. One of the things they do, you come up a ways, you'll have decompression stops to let the bubbles go out. If you don't do it right, your small bubbles combine, forming larger bubbles that cause blood vessels blockage, severe pain, major complications. This occurs in scuba divers who stay at depth too long, ascend too rapidly, or do repeated dives without allowing enough time for the body to recover. Another thing, they tell you after you dive, there's a period of time where you can't fly. They don't want you going up into a higher altitude than sea level. Okay, we talk about patients doubling up from abdominal pain and joint pain. Presents like air embolism. However, air embolism typically occurs immediately on return to the surface. DCS, decompression sickness, that's the bends, may not occur for several hours. They talk about, much like what I told you about the bottle, the balloon with the air, consider a bottle of carbonated soda. The fizz is dissolved in the liquid soda. You take the lid off, the pressure in the bottle is released, causing the carbon dioxide bubbles to form. In a diver who's ascended from depth, dissolved nitrogen in the blood forms bubbles as the pressure of the water is reduced by ascent. Bubbles migrate into the bloodstream and into the tissues, causing severe muscular and joint pain. Sometimes large nitrogen bubbles can become emboli and block blood flow to critical organs. A lot of words here, but serious stuff. We talk about DCS, decompression sickness, could be made worse by insufficient hydration, increased respiratory rate at depth, carbon dioxide retention, colder temperatures, cigarettes or alcohol consumption, exertion during a dive. Okay, this is, so we look at, let's kind of talk about this. What do you do about the bends? Well, basically, what they have to do is get the person to a decompression chamber. And they put them in a tank, increase the pressure, get the bubbles to dissolve in the blood, and gradually bring them out of it to back to the normal normal temperature. Here we talk about swimmer's ear. That's an acute bacterial infection of the ear canal. If you're in the water too long, it washes out the good things, puts the bacteria in. You get an infection called swimmer's ear. Typically, severe ear pain, yellowish discharge, tinnitus upon pressing on the anatomic bump in front of the ear canal. Most susceptible are kids and teenagers or people with diabetes and immune system disorders. Some of the preventive treatments are mildly acetic or alcohol-based solution that make the ear canal dry and inhospitable to bacteria. We're looking at patient assessment. Assessment of patients with a water-related emergency starts with ensuring the safety of yourself and others. Safety measures may include putting on a PFD, that's a life vest, a helmet or other safety equipment, but a PFD, personal flotation device. Use standard precautions. If you're not trained in water rescue techniques, don't have the proper equipment, wait for the arrival of specialized water rescuers. Don't become another problem. Once the scene is safe, you want to quickly assess the ABCDs, correct all potential threats to life, perform CPR if necessary. Remember, patients are not dead until they are warm and dead, especially in cold water drowning. In any submersive injury, carefully assess and protect the spine to prevent additional neurological injury. You want to shape before the water. It may be easier to apply a cervical collar and place the patient onto a backboard in shallow water than to perform these procedures after you remove the patient from the water. Again, we're talking about somebody dives in, hits their head. We're talking about spinal fractures, spinal cord injuries may complicate drowning. Spinal motion restriction may be needed. Spine trauma may be present if the following has occurred. Submersion issue is associated with a diving mishap or fall from height. If the patient is unresponsive, there's no witness to the drowning, particularly in ocean surface. And if we see symptoms such as weakness, paralysis, or numbness in the arms or legs. Unless the patient has serious or life-threatening injuries, perform a complete secondary assessment using DCAP BTLS, deformity, contusions, abrasions, avulsions, punctures, penetrations, burns, bleeding, bruises, tenderness, lacerations, and swelling. Additionally, perform a complete neurological exam on all non-critical patients. Again, this is if they've had an impact with the water or possibly the bottom of the pool. Assess the vital signs, the level of responsiveness, the skin condition, capillary refill. As part of the history, attempt to obtain as much information as possible about what has occurred. How long was the person submerged? Water temperature and salinity. Patient's appearance immediately after being removed from the water. Determine if the patient had any previous medical conditions or is taking any medications. Signs of arterial gas embolism. Signs and symptoms of AGE. Blotching or mottling of the skin. Frothing, severe pain, shortness of breath, dizziness, cough, cyanosis, vision problems, paralysis or coma, irregular pulse. These are situations that you'd see when somebody's been diving, not just somebody who's been swimming. Decompression sickness, pain, numbness, headache, similar, but cutaneous skin or problems such as itch or rash, muscle weakness. More signs of decompression sickness, impaired mental status, breathing difficulties, impaired coordination, reduced level of consciousness, swelling, retention of urine, compromised cardiovascular function. We talk about symptoms of swimmer's ear, foul smelling, purulent material in the ear canal, pain in the ear, redness in the external ear canal, and difficulty hearing in that ear. Now we'll talk a little about management. Before I can continue on, anybody have any comments, any questions? I kind of feel like if you read the book, it's a refresher. If you haven't, I'm fire hosing you and throwing it at you. But I think we look at it, we talk about drowning. We know what that is. That's when the water gets in our lungs, our throat constricts. We went through a process that showed how it ends with cardiac stopping. We talk about when you go underwater, if you're going to be a diver, a scuba diver, you go down gradually, you come up gradually. You're watching for pressure in your ears. Pretty simple. Any of you who dived down to the bottom of a pool and your ears hurt? My initial reaction is I didn't want to scuba dive because my ears hurt just to the bottom of the pool. Well, I found out when I've got the mask on, you breathe and you pop your ears and everything is fine. It's much easier. We talk about if you come up too quickly and you don't expel your air, you can blow out your lungs. Real simple. Getting rid of all the technical jargon. That's what happens. Similarly, if you're down too long, you make repeated dives. You're down deep. The nitrogen dissolves in your blood. You have to come up slowly. You have to have safety stops. Very often they'll have an oxygen bottle hung down at a level below the boat, so you don't run out of oxygen. You just breathe the extra air as you come up because you've got to let the gas come out of your body. They also talk about not taking a plane trip a short time after a dive. We talked about if you've got somebody who has dove, whatever it is, into a pool, they hit the bottom, into a lake, they hit the bottom, or they go in from a high depth off a board, they could have spinal injury. We talk about this. We talk about if somebody is drowned, or you can give them rescue breaths while they're in the water, but you really can't do the chest compressions. If you have that situation, you remove the person from the water, open the airway, simultaneously check for breathing and a carotid pulse. If no breathing or pulse, begin CPR, but start the cycle with 2 breaths. What's the normal, we start CPR, what's the normal number of breaths we give? Abigail, what would you say?
For regular CPR?
When we do normal CPR, we start out, how many breaths do we give?
Don't you usually start with compressions?
Yeah, but how many breaths?
2.
Well, I want to say, okay, what's the normal cycle on CPR?
30 and 2.
Okay, good. Okay. Patient has a pulse but not breathing. We begin the rescue breathing. There's no evidence that the water in the respiratory system acts as an obstructive foreign body, so don't attempt to remove it. Obviously, turn the person on their side and get them to spit the water out. Maneuvers to relieve foreign body airway obstructions are not recommended because such maneuvers are not necessary. They can cause injury, vomiting, and delay of CPR. Again, 911. If you're by yourself, you've got rescuing a drowning vehicle, it's reasonable, a victim, that's not a vehicle. Vehicles don't drown. When you're rescuing a drowning victim of any age and you're by yourself, it's reasonable for the lone OEC technician to give 5 cycles of CPR before leaving the victim to activate the EMS system. All patients who have suffered a submersion injury should be transported to the nearest hospital for further evaluation, even if they seem to fully recover following appropriate field care. Okay, we talk about ascent emergencies or descent emergencies. Special care should be transported by ground to a facility with a hypobaric, that's a pressure chamber. Repressurization, administration of supplemental oxygen are required to treat these disorders definitively. All patients who appear to be dead after removed from cold water should receive CPR and be transported to the hospital. Severe bradycardia induced by submersion in the cold water can make the person appear to be pulseless. These patients can often be successfully resuscitated even after an extended period of time in the water. So cold water, the mammalian reflex, they may be alive, we didn't realize it. So transport them to the hospital even if they appear to be dead. Swimmer's ear, best treated by keeping the external ear and eardrum dry. Antibiotics are needed when the infection occurs. We've got some simple case studies. You and several friends are at the ski resort's heated outdoor swimming pool when you hear for help. As you near the scene in street clothes, you come upon bystanders who tell you someone is drowning. You see a teenage girl floating face down in the water just under the diving board. You have somebody stop people from using the diving board. Scene safety. There's a cervical collar and a spine board nearby. You enter the water with help and quickly remove the girl from the water, protecting her neck. She's unresponsive. She is cyanotic, and you notice she has a large gash on top of her head. What should you do? Who wants to make some guesses here?
If you're approaching a victim in the water and you suspect a spinal injury, you want to move as gently as possible so you don't disturb the water, because that can exacerbate the spinal injury. So you're going to want to get there fast. You don't want to panic, though. You want to like walk gently through the water.
Okay, she's unresponsive, so she's probably not going to panic, but that's a good comment, Abigail. Is it Abby?
Abby, yeah. No, I know she's not going to panic, but you might panic, but you still want to get there gently.
Yeah, I would panic probably. John, you have any comments? Peter, go ahead, John. John, you're chopping out. Your internet connection is chopping on you. Peter, any comments?
Once you get her out the water, start CPR, right?
Okay, let's take a look. Okay,
Get her face up and get her rescue breath right away, because good chance she's just going to start breathing, even with a head hit.
Okay. Now we did say
ABCs first.
I'm sorry.
Before CPR, you want to do ABCs.
Right.
Well, would you do like emergency move here? Because she is like just face down in the water, so you just try to get her out of there as soon as you can.
Well,
yeah, you have to be cautious of the high suspicion of spinal.
Yeah.
You have a spine board. It's best to try and bring them out on the spine board from the water. I'm a lifeguard, by the way.
Okay. That makes more sense. Yeah, I'm like, I don't know how this makes sense, but I trust you, Abby.
Okay.
This is okay. This is kind of weird. I managed to pop. All right. Okay. Here is what they suggested in the book. You direct one of your friends to call 911 to get EMS help. The gash on the head and the shallow water suggest a cervical spine injury. So you protect the spine as you correct the ABCDs. Using a draw thrust, you open the airway, assess the carotid pulse, look for breaths. She's not breathing. She has a weak carotid pulse at 60 beats per minute. Her skin is cool to the touch. A cervical collar is supplied to the patient's neck. A bystander says she knows CPR, so she begins rescue breathing with a pocket mask, the pocket mask you have with you. You're holding the patient's neck in alignment. Now, what should you do next? Come on, you guys make a guess.
You're pretty much stuck with CPR until somebody else comes.
Okay.
Well, I think we're stuck with rescue breathing for sure, because you did say she has a pulse of 60 a minute.
Let's take a look. See what I did it again.
You're going to continue to assess her pulse, but
Okay, here's what they're suggesting. Rescue breathing continues. You cover with towels, so on to keep her warm. The head and neck are kept aligned. Within a few minutes, she starts to breathe on her own. Oxygen is provided. Full spinal motion restriction is applied. Vital signs improve. Patient is transferred to a trauma center where she's diagnosed with a cervical spine fracture. Although her road to recovery will be long, she's expected to regain full neurological function after spine surgery. Any other comments? Okay. If you don't have any other comments, I want to thank you for putting up with me tonight. And I'm looking to, well, you've just about book finished. Looking forward to seeing you on the Hill, and appreciate all the time you're putting in. It'll be worth it, believe me. It really will be. And thank you for volunteering to do this. Are there anybody got any questions that I might answer? Either part of the book or not part of the book. Any other questions?
Thank you, Bob.
Alrighty, everybody, have a good evening. Please stay safe and protect yourself from COVID.
You too, Bob. Thank you so much for tonight.